serve on the board of 2020 Gene Systems, Gene-Centric Therapeutics, and the Personalized Medicine Coalition. I've triple boarded, I've worked in all segments of healthcare delivery, academics, private practice, as well as managed care. I have a Master's of Public Health through the NIH. I'm also a Harvard Business School alum. I have industry experience. I was at Foundation Medicine before we were acquired by Roche, looking at picking the right drug for the right patient at the right time. Huge amounts of data that was generated through genomic sequencing, so multi-omics. And then after that, I took on a position as Senior Vice President at LabCorp. And so that is my background. I'm also a military guy, Air Force doc, 20 years, and that's what I'm going to focus on, is how do we apply the lessons that I've seen in healthcare and take advantage of what Carl just said. We live in this awesome time, an awesome time where we take advantage of what AI can do to improve patient lives, which is really, honestly, that's why I do what I do, which is, if somebody asks me what's your personal mission, it's to improve patient lives. So when I think about a patient, there's a journey. And this journey starts from a diagnosis. We can think about prognosis. We can think about then, well, how are we monitoring treatments? And then we can think about, say, predictive data, right? Predictive, algorithms to say, well, is this drug going to work for this particular patient? And so there's many, many ways to do this. And what I've spent most of my life doing is trying to figure this out in cancer patients. And this has been remarkable. Like Jimmy Carter. Jimmy Carter took advantage of a set of therapies, immunotherapies. There's the PD-1, PD-L1 axis. There's many more than that, right? So there's inhibitory and also stimulatory pathways in the immune system. And he wouldn't have done as well as he did if we didn't understand how to test for those patients. And then ultimately, how do we get the clinical trials done? And then lastly, that's great innovation, but is it going to get in the hands of people? And these are some of the challenges that I think AI can help bridge. I mean, obviously the foundation is data science, but then we have to look at how AI technology can then bridge all of these challenges across the entire patient journey, right? From screening to diagnosis, again, to prognosis, to understanding whether the patient's getting better or worse. And then finally, actually saying, hey, can we actually pick therapies? Can we design therapies, whether that's on clinical trial or standard of care? So there's a tremendous amount of opportunity, tremendous data sets. Our sister company, when I was at Foundation Medicine, was called Flatiron. I think many of you would probably know who that is. A lot of real-world evidence, real-world data that Flatiron was working on. And the reason why we picked oncology, why Roche ultimately, when they completed the acquisition of Foundation for about $5 billion, was oncology has the most data. And so we should be able to tap into that data, look at real-world evidence, tap into the genomics and other laboratory data sets, and then come up with mechanisms to improve patient lives. This is another lens that I think is critical for the folks in this room to double down on. Because when I think about what we need to do, I think about diagnostics. As a cancer doc, and I've worked for 20 years, historically we'd say physical exam and the clinical history. Both still very important, but diagnostics is quickly replacing that with not subjective, but objective data. That's not to say that we need analytic and clinical validity to ensure that diagnostics is capturing whatever measure we're saying it's capturing. But the truth is, imaging data, laboratory data, and kind of in between, the combination of laboratory and imaging, slides and looking at the imaging data of pathology, is critical. That is going to provide the insights we need to understand the biology of disease, not just in cancer, but all human illness. And the question is, how do we get those data sets? One of the reasons why I wound up at LabCorp, and I was talking to Antonio earlier, is we touch half of the, when I was at LabCorp, we touched half the patients in the country. And so the thought process here is we need to get access to that. And then now, since patients have access to their own data, the question is there a different value prop we can give and say, hey, we already have the lab data, but it's an incomplete data set. We need the clinical data to match the lab data so we can, get the most insights out of that. And then with AI sitting on top of it, learn. not just a monovariate analysis of why a particular patient does well if they have an EGFR mutation in their lung cancer, but what if they have a secondary mutation that is either going to help that patient or is going to be a resistance one? Right now, we're still like in the Stone Ages of trying to understand that biology, and I think data science and AI can accelerate that. Same thing with therapeutics, right? So if you look at surgery and radiotherapy, robotics, AI has immediate implications there. But I would argue, if you look at drugs, again, I apologize for the formatting here, I don't know what happened, but whether you're looking at traditional therapies, like say chemotherapies, or small molecules, targeted therapies, or immunotherapies, or cellular gene therapies, the data that we're generating is massive, it's critical. That's the foundation. For us to apply AI technologies, what we need to do is have the right data sets. Then the secondary question is, where are we going to get the value, right? And that's asking the right questions. To me, those are the harder things, right? We can train, but if we're training on the wrong things, we're going to get the wrong answers. And that has massive implications for public health, right? And so that's why it's critical. And then, again, Watson tried to do a version of this. Why did it fail? Well, it failed because healthcare delivery, healthcare implementation is different, right? Depending on where you practice. How I practice in an academic center is different than if I'm in private practice. Maybe we can argue it shouldn't be that way. But that's the fact. And we got to figure out how 70% of the patients in this country that get treated in the community setting are going to get the benefit of all of the great innovations that we're making. So it's critically important that we understand delivery systems and thinking about, say, telemedicine or chatbots or other mechanisms that AI could play a role to shrink that education gap, because rising tides need to lift all boats. We can't sit in our White Castles and academic centers and say, well, you should have done this while patients suffer. That is where AI can come in and help bridge some of those gaps. I'm really excited about that possibility as well. Again, here, this is fresh, and I'll talk a little bit of the last slide here, on policy. But we have to figure out how data science is going to lead to these solutions. And again, as I said, if you look at HHS, this was published just days ago. And these are the 4 goals of the AI strategic plan for HHS, right? Catalyze health AI innovation, trustworthy AI development, democratizing, so some of that is access, like, making sure there's equity in some of the things that we're doing. And then, of course, making sure that, AI is part of our workforces and organizational cultures, because it's here. No room knows that better than the folks in this room, right? Whereas the average person sitting in, Paducah, Kentucky, or wherever, they don't know that yet, but they will. And the folks in this room can make that happen. And that's why I'm so excited about what the future holds. So these are examples, right? AACR, ASCO, ASH, these are the big conferences for me where people are actually using AI and making a difference in either healthcare delivery, or they're making differences in trying to think about who to pick for a particular therapy, right? Again, I put these slides up because these are literally days old, right? And so, prediction of checkpoint inhibitor immunotherapy efficacy. So how do we decide who's going to benefit? I know we don't have time to talk about this, but I know the technical stuff on the biomarker side. Is it, something called HRD, homologous recombination deficiency scores? Is it, tumor mutational burden? Is it microsatellite instability? Is it, specific mutations like POL mutations? There's a lot of data here, but AI is smarter than I am. And it can look at that data and it can help us understand how to pick the right patient for the right drug. Right? The same thing is true on imaging. We knew this, like the company I was working for was based out of Cambridge, and a lot of the folks I work with were in the Harvard medical system. And we know in Boston, when you look at Harvard-trained mammographers versus using AI to look at those mammograms, AI did better. Doesn't mean we're going to replace all those docs. But we're here to improve patient lives and be complements to what physicians are already doing. The same thing is true in pathology, right? So, I have lots of friends in the pathology world. I called Andy Beck, who's the CEO of Path AI, and I said, hey, Andy, I'm talking here today. Give me some slides.
So he sent me some slides, right? So the bottom line is that there is a massive, massive market, and that's that on the right there, the digital pathology total available market penetration, where we hardly have any market penetration. And again, we don't have time today to talk about that, but that goes back to healthcare delivery systems. Where's pathology done? Where's that data stored? How are you going to make that part of the workflow for typical pathologists? These things are very complicated things, to fix from a process perspective. But you can have an awesome business, generate lots of revenue, and make a difference for people, right? They're not exclusionary. And that is what we're sitting at, right? And here's an example of that. The left is just simple H&E. And you can look at how much data you can glean from that. And the right is an AI system where it's basically looking at whether the tissue is normal, does it have cancer cells, is there necrosis, is there supportive structure, which the microenvironment is also important, and also the different kinds of cells within that support infrastructure, right? That is tremendous amounts of information. Looking at the same darn slide, but analyzing it differently, right? I could say the same thing about laboratory. When you look at something like hemoglobin, something as simple measures hemoglobin, we use it for certain things today, but what are we not understanding is hemoglobin is a predictive marker for many other potential outcomes, clinical outcomes. So there's what we're doing today, and there's what it could be in the future. And so that's what's so exciting to me about what's coming up. So who cares? Again, I said this earlier, but I'll say it again. Who cares when you have these awesome tools and it doesn't get to the people? And so the risk here is that if we're not careful in the space of AI, just like for CGP, comprehensive genomic profiling, you're going to get biased data sets, or you're going to get increase in disparities, not decrease in disparities. And the reason why this is really important, I'll give you a simple example. Again, I'll go back to EGFR. One of my clinical mentors, his name is Vince Miller, who's at Memorial Sloan Kettering, and Vince's lab discovered EGFR in lung cancer, one of the most important discoveries in lung cancer. And what I'll tell you is that everything's not the same. So when we first did the trials for EGFR, we did not look in lung cancer whether a patient had that mutation or not, and they failed those clinical trials. Then we looked to say, okay, who's got an EGFR mutation? And they worked. But here's the problem. EGFR mutation rates in Asia, about 50%. EGFR mutation rates in the Caucasian population, about 20%. African Americans, different. Hispanics, different. So if we're testing or we're trying to glean our teaching sets for how we're going to then, tell AI to do what it needs to do to give us advice, we better have the right training sets. And this is where, if we don't be careful, especially in healthcare, we're going to be at risk of causing problems, and these are population-level problems if we're not careful. So we've got to ensure that, when we're saying that, hey, this is a genomic data set, and I can't think of a better place for a public-private partnership than that, to work with government, to work with us in industry to help enable this, right? I want to look at population-level data sets. This is where the public-private partnership can really bear some significant fruit. And, if we don't do this, we're going to miss the market. And it's critical that we don't forget about this. So I didn't mention this, but, I got about 6 minutes left. I'm going to leave about 5 minutes for, let's have a discussion. But I ran for Congress. It wasn't that one day I rolled to the right and said, I'm going to run for God. I've never run for anything. I didn't even run for dog catcher, right? But I was asked to run. And so I said no, but then what I realized is that policy matters. And I think everybody in this room, a lot of doctors, they don't understand this. I mean, I'm a goofy doctor. More, understand the business end of things. And not because and just want to make money, but if you don't understand the business ends of things, you're not going to be able to effectively deliver. Because if you can't make that economic argument, it's going to be hard to do the things we need to do to get these things to the hands of patients. Okay, but I looked. Okay, 50 states, all of them, had some form of AI legislation last year. 31 states passed that legislation. I looked at federal recommendations. As I said, just last week, HHS delivered, kind of their strategic plan for AI, and what they recommend in healthcare. About November, what is that, 2 months ago, the first digital advisory group came together for the FDA to say, hey, what do we recommend, right? They had primarily 4 main recommendations, right? Some of it had to do with how we're going to track safety issues, making sure patients understand, when AI is being applied, and so on and so forth. So we don't have the time to talk about all of this. I will just suffice it to say, if you are not at the table, like this big table here, you're on the menu. And I know this now because I've done this in healthcare, how we think about models of value-based care and how we pay for healthcare. The same thing's true of any business sector, right? And so I've seen it now in clinical delivery, I've seen it now in corporate America, and now I've seen it deeply, as running for the US House on the political end. And one of the reasons why I ran is because when I was trying to do the things I was doing at LabCorp, some of the policymakers, they were setting up legislation that was contrary to what I thought was good patient care. And then all of a sudden, the same people that were, setting up these, bills, for votes, they were calling me to say, hey, will you please run? And I said, okay, wait a second here. I got to at least consider this because I can bridge that gap. And by the way, folks, we can lobby all day long. We better get champions of the things that we want into office, right? Whether that's, the executive branch or the legislative, maybe to a lesser extent even judicial, but the thought process here is we got to make sure that we have champions for the things that we want to do. Otherwise, we won't effectively be able to get that. You will pay less if you have a champion than trying to lobby for somebody. So don't forget that as a critical thing. And again, I can share whole kinds of stories about the political process. Some great, some not so great. But the bottom line is we got to take advantage of this. I'm going to stop talking here for a second. There's probably questions. Feel free to, jump in. Yes.
I like your 810 tip.
Appreciate it. So it's my airframe for 20 years. So it's 442nd Fighter Wing. I'm part of the team. They did great work to protect our freedoms. So they have since 9/11. They've been very important, proven closer. So thank you for that shout out. Yes.
My name is Shailesh Tate. I'm CEO of Silicogenics, a spin out of the Laboratory for Research in Complex Systems, which is also what I run. And I'm also Associate Adjunct Professor of Epidemiology and Biostatistics at UCSF. Why do you care so much about what the government thinks?
Because policy impacts our lives. And so the truth is that when we have a vacuum, if we don't step up and get people to be our proxies to help us shape good policy, that's going to affect our ability to deliver an effective business solution. That's the simple truth, right? So,
yeah. One of the funny jokes I've heard is Silicon Valley is successful because it's so far away from Washington.
True, but Washington's coming to Silicon Valley. That's the problem, right? So if we don't tackle this, they're gonna make it hard.
Yeah, that's right. The thing that the reason why I asked this question is that the government sees things from a very different point of view from say what the industry sees, right? As pharma, we would see things very differently than what the government. The government has a different set of priorities, right? And so how do we bridge those? Because that's where we have.
It's a great thing. I would just maybe subtly shift a little bit. I think we should all have the same priorities. Value, right? We got to be able to justify the things that we're doing, right? We're not academic centers saying we want unlimited funds. We have things to deliver on, and if we can't deliver on those things, right? I'm saying purely from a product or service perspective, right? If you're in a business, those are challenges, right? This is again, look, there's a role for government. I personally, my personal opinion is I prefer smaller government so people can innovate and people can deliver on the promises because there's a lot of brain power here and there's a lot of unmet need and I would like to support. So how do we fix that? Number one, we get champions. We have to get champions into these decision-making positions. Number two,
On the back end, healthcare implementation science could benefit as much from AI and say healthcare delivery as what we're talking at, say, opening up, say, drug pipelines or diagnostics, new novel algorithms to, to basically describe pathobiology. So the short answer is if we don't do this, we're going to repeat the mistakes of history, which is we will stumble because there's a vacuum, and people who maybe don't know as much as the people in this room are going to be making those policies. And yes, this is a space that's been mostly not really interfered with. That interference is coming in a big way. And this is at the state level, this is at the federal level, this is through the executive departments. This is coming. And if we're not serious about it, it's gonna cause problems.
Thank you.
Yes.
Any other questions? We might get feedback if it's too close to that.
Just one last question. In the perspective of being at the table or on the menu, with the speed of innovation that's happening right now, especially in the AI space, and the number of innovations and breakthroughs that are happening, without guardrails, how do you think that it will affect policy going forward?
Carl, I think we should continue this conversation tonight with some alcohol. Because my 15-second answer is probably not going to solve that, right? I mean, the truth is that I personally believe information in and of itself is never evil or bad, right? It's what we do with that. That's where the guardrails belong, right? And so we have to be thoughtful about that. But we are going to hurt patients. And earlier today, I was talking to a handful of folks. I said in medicine, we have a simple kind of philosophy. I can't help everybody. But gosh darn it, if I know that this particular patient has something that I should have known, and I don't help them, bad on me. That is like the worst thing you can do. When you know that this person, if I looked and I knew that, I could definitely help that person. Well, guess what we have? We have that aggregated data. We have the know-how of how to do this. And bad on us and bad on society if we put roadblocks in place that prevent us from maximizing the power of AI to improve human